For that really excellent presentation. What a great way to start our meeting today. We're going to shift now into our first panel of the day, which is on the intersection of mHealth and behavioral health. And as you'll see, we have an outstanding lineup of panelists here who are seated in the front. I'm pleased to co-chair this session with my colleague here, Andrew Campbell, who's a professor of computer science here at Dartmouth. What I'd like to do is just to take a few minutes to orient you a bit to this panel and the purpose of this panel and why we have a session on behavioral health as part of this. And I would argue that this is having behavioral health as a central part of what we do in the mobile and wireless health space is really critical. So I'm just going to talk a little bit about that and the significance of this topic, and then each of the panelists will talk a bit about their work, and I'll tell you a bit when we get to that phase as to how we're going to structure their presentations. So in terms of background to this, there's been quite a lot of research and development activities applying mobile health approaches to issues of behavioral health. And these include a wide array of applications, including applications focused on behavioral self-monitoring, on self-management kinds of approaches to promote health behavior, as well as in creating decision support tools around health-related decisions, and have been used to address a wide array of topics. So issues such as substance use, such as mental health and mental illness, such as medication taking, and also around health promotion and wellness. And you see that these include applications for clinical populations, as well as prevention and wellness-focused types of applications. Some folks refer to this as sort of the quantified self movement, really tracking behavior, using data to gain self-knowledge. And lots of opportunities and models for deployment of these types of tools, both within healthcare systems as well as standalone self-directed tools for consumers to use as they move about their daily lives. And the work in this space to date has been really promising and has really underscored that if you develop these tools well, you can get outcomes that are quite promising. So you can get outcomes where these tools can be highly useful and acceptable to many diverse populations. They can have a large impact on health behavior and health outcomes. You can see increased quality, reach, and personalization of care. These tools can be cost-effective, and they can prevent costly escalation of problems. If you can monitor and detect problems early on, you can prevent escalation and unnecessary healthcare utilization by having these on-demand, 24/7 available tools. And they can be responsible to individuals' health behavior trajectory over time. And I'd like to just underscore here with the next few slides why behavioral health is such a significant issue and why this is an important focus as we talk today about health information technology. First of all, these behaviors are very common. So if you look at statistics around mental health and substance use, you see that some estimates are that about 1 in 4 to 1 in 5 adults in the US, these are US stats, are diagnosable with one or more mental health disorders. And about 1 in 10 adults are diagnosable with substance use disorders. And you see that folks with behavioral health disorders are among the most frequent utilizers and the costliest utilizers of our healthcare systems. So annual economic costs of mental health disorders, for example, are currently estimated at over $300 billion in the US, and you see that this is markedly increased. So estimates in '96, for example, were about $35 billion. If you look globally, World Health Organization estimates that mental illness accounts for more disability in developed countries than many other groups of illnesses, including things like cancer and heart disease. So these issues are important in their own regard. We also see significant relationships between behavioral health and chronic disease management. So you see that behavioral health disorders are highly prevalent among clinical populations with chronic physical health conditions. There are about 133 million Americans that are living with chronic diseases. That's about 45% of the US population meeting criteria for one or more chronic physical health conditions. And this is accounting for over 75% of healthcare costs in this country. And what you see is that there's really high comorbidity between behavioral health disorders and these chronic physical health conditions. So for example, persons with diabetes have about 42 to 72% incidence of depression and about 50% incidence of anxiety. And what you see is when these things co-occur, you see typically worse outcomes. So behavioral health disorders typically complicate and worsen the course of treatment of chronic medical illnesses. You see lower quality of life, You see poorer response to treatment, worse medical and psychiatric outcomes, higher mortality, and higher cost of care. So again, as an example, when depression co-occurs with diabetes, you see healthcare costs increase by about 50 to 75%. So there's significant economic considerations as well. So there's a real opportunity to think about targeting behavioral health, targeting the intersection of behavioral health and chronic disease management. And I think this is particularly timely in thinking about mHealth approaches around this, given what's evolving in the US healthcare system. And I'm just talking here about US healthcare system. We have a whole panel this afternoon on global health. And a lot of these issues are relevant in that space as well. But in the US, we see as the Affordable Care Act is unfolding, there are lots of interesting changes that we expect to occur that really, I think, presents a unique opportunity for thinking about technology as part of what's unfolding with integrated physical and behavioral health care in this country. So, for example, the ACA is requiring that healthcare settings, which have traditionally focused on physical health conditions, now must offer substance use and mental health care as well. So in some traditional medical homes, it was the case that you could sort of outsource or ship out those transfer elsewhere individuals with problematic substance use or mental health problems. But now if you're responsible for the entirety of care of individuals as part of this accountable care model, it really creates an opportunity to think about how to do that well in a way that really integrates behavioral health. We also know that Medicaid eligibility is expected to expand and provide coverage for the first time to, the latest stats are about 32 million individuals. And the data show that many of these persons that are going to get insurance for the first time often are poor, unemployed, and we see disproportionately high rates of behavioral health disorders among this group. So there's a real need, and I think there's a real promise in thinking about what we're talking about here today, mobile and wireless technology, as part of this evolving integration of behavioral and physical health, and thinking about these types of approaches and addressing the behavioral health dimensions of chronic disease management and thinking about new healthcare service delivery models. So that's what we're talking about today. Here's our panel. I don't think we lined up the pictures with the order of where folks are sitting, but this is our panel. Dave Gustafson is going to be our first speaker from the University of Wisconsin-Madison, and then Sarah Lord, Tim Bickmore, and Niels Rosenquist. The way we're going to structure this is each panelist is going to have about 10 or so minutes to make some opening comments, and then we're going to open it up for discussion, and the panelists can engage more with the audience around these topics. And I'll introduce each person as we go along. And again, just a reminder that our discussion here is being recorded. So our first speaker, I am very pleased to introduce my friend and colleague, Dave Gustafson, who's an engineer at the University of Wisconsin-Madison and directs many, many research centers, more than anyone I know, has an array of centers around health enhancement systems, including a center on aging, a center on cancer communication, has a strong focus on addiction research, including models of implementation science, and as well as thinking about technology for individual behavior change. So it's my pleasure to introduce Dave.
Hi, I got to talk fast because I only have a couple of minutes. Not true. Anyway, thanks, Lisa. It's a pleasure to be here. What I'm going to do is break this short discussion into three things. The first thing I want to touch base on is a vision that we implemented of how you might use mobile health to try to help people who are dealing with addictions. The second thing I'm going to do is to show you what happened in a randomized trial and also field test of that. Then the third thing I'm going to do is to show you a little bit about the work that we're doing now in a slightly different field. It's aging as opposed to addiction, but just to show where we think it makes sense to go with this kind of stuff. The system that I'll be talking about is a system called the HS, addiction is its focus, and it has about 18 different services in it, all on a mobile phone. Some of it relates to social support, the thing in the upper left-hand corner. Some of it relates to virtual counseling, some of it to education and training, some of it to location tracking and assessments and alerts. This is, if you want to, this has a bunch of little videos in it. I'm only going to show you one. If you want to go on the whole site, it's just called Innovations for Recovery. Innovations, plural, for FOR, recovery. And for those of you who have seen this 2-minute video, bear with me, you're going to see it again. Oh, dear. Pardon me? Oh, okay. And I'm going to need to have you guys...
In the very back seat of the number 12 bus, only Jeremy's eyes were moving as he scanned the shadows outside, his forehead pressed against the glass. He had missed his stop. It was 1:30 in the morning, and when the bus had approached his street, he had imagined lifting his arm up to pull the cord. He'd imagined himself walking up the stairs to his crappy apartment. He'd imagined himself flop into his grubby, sunken couch and pull his tiny TV close enough to watch. But he hadn't pulled the cord. He was motionless, with a tiny spark of excitement and a tiny spark of nausea circling like flies in his stomach. The park 10 minutes ahead on the bus line was where he used to score. He could feel it getting closer, though he couldn't see it. He had no intention of getting off the bus at the park. He just wanted to drift by and catch a glimpse. He was shaken out of his trance when his mobile phone went off. It was Chip's ringtone. Jeremy always answered when Chip called. He didn't want to miss out on an easy $10, which his counselor would give him for each week he didn't miss a response. Chip was a virtual counselor, a graphical representation of software designed to assist sober network users. Chip had been tailored to Jeremy's needs during his last stint in rehab. Jeremy liked that Chip could speak and listen, much like a real person, as Jeremy wasn't very comfortable with using the text menus to access his sober network services. Chip knows that Jeremy is a night owl, and oftentimes he'll call late, just to check in. Chip had already called Jeremy around midnight, but he was calling again because the GPS embedded in Jeremy's phone had alerted Chip that he was near a high-risk location. After Jeremy answered a few of Chip's questions, Chip had some suggestions for Jeremy. Chip said he thought it was very important that Jeremy have a video conference with an on-call counselor right away. Jeremy didn't think that was necessary. When he told this to Chip, Chip reminded him of what life could be like if he were to relapse. As soon as Jeremy said, "Fine, I'll talk to him," Chip set to work making the connection. Jeremy looked around. The bus had passed the park, and he was heading back west. "I'm the only one in here," he thought. "This shouldn't be so bad." He sat up a little straighter and positioned the phone in front of him. Within a minute, he was talking face-to-face with his counselor, Jeff.
That we developed, and now what I want to do is talk about what we've learned from that process. First point is that it wasn't an old Palm phone that you saw on the screen. It was actually an Android or an iPhone that we actually used. And one of the things that we did was to carry out a randomized trial of about 350 people who had, half of whom had access to this particular system as they were discharged from inpatient addiction treatment. And they were given the phone for 8 months, and after that we watched what happened for another 4 months. And we compared that to treatment as usual for these particular patients. And what we found was that the system was pretty effective, that on average it reduced risky drinking or heavy drinking by about 57%, which was better than we had hoped for, and was I thought, a really exciting finding. There were other findings from it, but because of the time that limitations here, I want to move on to a second field test of it. In this particular case, the Veterans Administration Hospital in Rochester, New York, combined HS with medication-assisted treatment and coaching, not counseling, but just having a peer mentor kind of person interacting with them. And they took 48 people who, over the previous 10 months, had a lot of readmissions to treatment. They gave those people the combined intervention, and there was an 84% reduction in readmissions. So the VA got pretty excited about that. So that summarizes, in a sense, one particular piece of work that we're doing, and that is using smartphones to help people who are dealing with addictions during a period of time after treatment, and sort of providing them with continuing care. Now, Lisa Marsch is, I think, a really an exciting colleague. I love working with her, and actually we're getting married, and I'll talk to you about that. But in any case, Lisa has developed a system she calls TES. I call it TESS. It takes the key cognitive behavior therapy principles or skills and trains people during treatment, whereas we do stuff after treatment, continuing care. Lisa's work jumps in during treatment and provides training, and then uses videos as a way of modeling the skills that the person is learning, and then carries out a really creative kind of testing of these particular systems to see whether the person has learned them or not. And they have done just a wide variety of studies on the effectiveness of this system. And in a couple of different studies, generally what you find is that if you look at continuous abstinence of a person and try to figure out the average continuous abstinence, the people who get tests, or whatever she calls it, have continuous abstinence about twice as long as people who get treatment usually. So I think that's pretty impressive. When I was a young researcher, I was working with the Papago Indian near Tucson, Arizona, and my wife Rhea was driving along in the car, and the clouds were beginning to form overhead, and clearly bad weather was coming, and she saw this Papago lady walking along the side of the road, so Rhea stopped and said, "Would you like to have a ride?" And the lady said yes. And she got in, but Rhea had a bottle of wine sitting on the seat next to her. And she said, "Oh, I got this for my husband." And the Papago woman said, "Good trade." So in any case, this marriage between Lisa and I may not necessarily be one that my wife resists, but might. In any case, we have a grant now to combine tests and chess into one seamless and fully integrated package, so that you really can't tell you're in tests or in chess. It's got the same interface and all this kind of stuff. And what we're trying to do is combine treatment, which is Lisa's stuff, with continuing care, which is our stuff, and then add in a module that we're developing on population management, and doing that all by smartphone. And we're about ready to start pilot testing that.
So I'd like to go ahead and introduce our next speaker, Sarah Lee, who is a faculty member here at the Dartmouth Psychiatric Research Center, and she heads up our Dissemination and Implementation Research Core at the Center for Technology and Behavioral Health. And as you'll see, Sarah's been involved in developing a lot of different technology-based assessment, prevention and intervention tools for youth and adults, focused on HIV, focused on substance use, focused on co-occurring issues. So, welcome, Sarah.
Thank you. Hi, everyone. So my charge here, this is the answer? This one? This right here? Okay. My charge today is to very rapidly provide you all with a sampling of the kind of work that's being done by folks at the Center for Technology and Behavioral Health. Many of the programs, so what I'm going to do, I'm going to go kind of fast. I may be speaking fast, but Lisa has a hook behind her chair, so I'll be presenting programs along the continuum of care that Wendy described earlier. So I think I'll just launch right into it. The first program of research I really wanted to describe, and I hope I do it justice, is led by our colleague Dror Ben-Zeev. He's really focused on self-management of schizophrenia, and he's developed a mobile application to aid in this self-management, which provides system prompts, on-demand resources, as well as a clinician dashboard. I'm just going to take you through several of the experiences. So a user would select voices if they were troubled or wanted to do some coping around their voices. They would then complete a clinical status assessment, which was all of these programs that I'm going to describe were developed with consumer input, user input. So the interfaces are really developed in a way to promote engagement by consumers. So the consumer completes a clinical assessment. They've been moderately bothered by voices. And then they receive feedback based on their response. In terms of the assessment of the problem, are the voices all-knowing? This is all based on cognitive behavioral principles. They then receive a cognitive intervention around challenging of negative beliefs around the voices, and then a behavioral strategy based on this belief set. So try this, and then we can talk about it later. In a pilot of this work, Dr. Ben-Zeev and colleagues have been able to reduce frequency of voices, to reduce negative beliefs related to voices, and to increase social interaction. So this new model is being tested currently, and we'll look forward to seeing what the results yield. Lisa Marsch is leading a program of research, and Dave has described a bit of it. This is a mobile psychosocial treatment. In this case, it's an adjunct to care, to substance abuse care. So this is, was piloted with a group of folks in methadone maintenance, correct? The mobile program includes a functional analysis of drug use, identification of triggers, a coping plan, and then consumers would receive prompts for coping skills twice daily to go into their coping plan. This was piloted with 50 new intakes in a methadone maintenance treatment setting for 12 weeks, and it was compared to a standard of care. So what we like to see with all kinds of mobile applications is demonstration of good feasibility and acceptability. In this case, this team, once again, has indicated great feasibility. Participants maintained their mobile phones. They were given mobile phones in this case. They maintained them. They used the program modules as intended, and they reported high levels of acceptability. So they thought it was useful, they thought it was easy to use, and they also reported using the intervention during times of heightened risk for use. So that's another great indicator when you're thinking about mHealth, that of engagement, that people are going to continue to use it. Also very positively, the pilots indicated that the folks that use the mobile intervention demonstrated higher retention in treatment, as well as longer periods of opioid abstinence, which is what was also found with the test program. I've been involved in thinking about the area of prevention and health promotion. I've been involved in this area for many years now. What I'm going to just show you as a sample here is this is one web-based prevention, health promotion web-based program that was a suite of web-based programs. In this case, this was focused on sexual health with the goal of improving condom use and sexual health in general. It's based on an information, motivation, behavior model. And it included a risk assessment with tailored motivational feedback, an area where you could go for interactive, all kinds of interactive activities about learning about STIs and HIV, an area where there were interactive coping skill development with videos, audio, quizzes, etc. There's an area that was updated to try to promote ongoing engagement, as well as a data reporting feature for administrators at colleges. So we tested this with a sample of 316 students from 7 colleges and universities across the country. Folks were asked to use the program 4 times over a 2-week period for at least 15 minutes. So that was the dosage. And we assessed them at post, 3-month, and 6-month follow-up. And the takeaway is we got really good sustained results in terms of at 6 months, we improved knowledge, we improved positive attitudes about condoms, and this was particularly the case for males, and that's really hard to do, to improve attitudes about condoms for young men. We improved intentions, preparatory intentions to carry condoms, intentions to use condoms, intentions to get tested, as well as condom use behavior. So folks, 3 months later, so folks used this program 4 times in a 2-week window, and these are the results from 6 months later. They were 3 times more likely to use condoms, and they were more likely to get tested. That was more of a trend effect. Another important metric from this study was that we had 92% retention at the 6-month follow-up, which means folks were engaged in the program. We did something right, and I think part of that is that we involved the end users in the development across the project plan. We also got very high acceptability on indicators of acceptability, satisfaction, and very good stickiness, if you will, in terms of the time they used the program. So we said, come on in for at least 15 minutes each time, and our average per site visit was 28 minutes. So we are using now that model as an infrastructure to develop an integrated mobile web text message intervention to promote HIV testing and condom use. In this case, with young people in New York City. So this is with a colleague at Mailman School of Public Health. We are, like with all of the other programs that we have developed, we're using a user-centered development approach where young people are actually the producers, and not just producers across the development plan, so not just in content development, but they've been involved in the formative work from the beginning. We're going to be testing that really around feasibility. So how are they going to use the text messages? What optimizes implementation of that program? We are also involved in the sensor sector. In terms of the passive sensor sampling and integration with mobile sensors. In this case, we're looking at, this is a small pilot where we're looking at mapping of smoking behavior and craving with wearable and mobile sensors. We're using a wearable wrist sensor that does sensor sampling of skin conductance, temperature, accelerometry, and includes an event marker. We're linking that with the mobile device and to do event marking sampling of ecological momentary assessments of use, craving, stress, and mood, with the whole goal of trying to determine precursor signatures of smoking so that ultimately we be able to do some proactive intervention. So finally, thank you. Finally, we're doing some work. We just started some work really in the area of enhancing care delivery and workflow. And in this case, it's for an evidence-based supported employment intervention that is called individual placement and support that has been developed by colleagues at the Dartmouth Psychiatric Research Center. We know that employment is a key aspect of recovery for folks with serious mental illness. And what IPS-supported employment is all about is helping people obtain and sustain competitive employment. It's a team support approach, and so it's a very hands-on approach. And we are working now, we've received funding from the Department of Education to develop a technology platform to build technology into the supported employment care delivery model in ways that we can improve self-management by consumers themselves so that there's ongoing learning, ongoing assessment, providing them at the ready coping skills and support when they're at work, all with the goal of promoting self-sufficiency and empowerment and efficacy. We're developing tablet-based assessment and treatment planning tools to improve collaboration in the job development process between the care team and consumers. And we're also developing a data management and data reporting platform so that with the goal of really assisting in the care management, case management process. The whole goal being to build efficiencies in care delivery, extend and access and reach to this very well-established evidence-based intervention that we know works. We want to just enhance it. And most importantly, to improve client outcomes and lives. And so hopefully that provides an overview of context for our discussion, and we do have postdoc opportunities available. Go to the website. Thank you.
Thanks so much. So I'd like to move on to introduce our third panelist, Dr. Tim Bickmore, who's a faculty member in Computer and Information Sciences at Northeastern University. And his work has been focused on developing and evaluating computer agents, avatars, that are designed to mimic real-world interactions between clinicians and clients to promote behavior change. So we'll be hearing about that.
Morning. Still morning, yes. So I'm going to be talking about a research program we've been conducting for the last few years, as Lisa said, on what I call relational agents, but a lot of you might know of as avatars. So I'm going to talk about the general research program for using these for automated health communication, and then some specific projects that we've done in the area of mental health and mHealth. So in our lab, our focus is on going out and studying one-on-one, face-to-face counseling between health providers and patients, and trying to understand sort of the nuances of the intricate dance that goes on in these brief counseling sessions around very focused topics. So we go out at the start of a project and we'll videotape doctor-patient communication or nurse-patient communication and then try and dissect that to understand what's said in the speech channel for therapeutic reasons, also the social cues that are used to build trust and rapport and therapeutic alliance over time. And then in the nonverbal channel, we're interested in looking at things like use of hand gestures for conveying meaning, eye gaze cues for turn-taking, eyebrows raises and head nods for emphasis, and facial displays of compassion and empathy for building trust and alliance. So our attitude is that if we want to build automated systems that can capture some of this essence, if we want to do hand gestures, we have to give the computers hands. If we want to do facial displays, we have to give it a face. So the systems we build look like this. This is a virtual discharge nurse that we developed in collaboration with Boston Medical Center. In this system, we wheel it up bedside just before a patient goes home, and we hand the patient their discharge instructions, and then the agent spends about half an hour with them, walking them through their self-care procedures post-discharge. And the nature of the interaction is the character talks using synthetic speech. That's because everything's dynamically assembled with a dialogue engine based on the patient's medical record, the questions that they ask, their particular needs. So it's a very dynamic, evolving conversation. And then in the nonverbal channel, we're doing things like simulation of these hand gestures and facial displays and so on in synchrony with the speech, based on theories of health communication and on studies that we've done. When it's the patient's turn to say something, they'd love to talk to the character, and they like that too, but to work reliably, we give them a list of things that they can say at each point in the conversation, and they select it off the touch screen. So we don't do unconstrained speech or natural language input. So we see very high levels of satisfaction and uptake. So Boston Medical Center is a safety net hospital. We have a lot of patients there with low levels of health literacy, a lot of patients who have never touched a computer before and wouldn't. But when the nurse brings us in and says, you just touch what you want to say, then the patient's generally off and running, and we see no problems at all across all levels of literacy. Okay, so why have cartoon characters talk to people about their health? I'll give you 3 quick reasons. So one is everybody knows how to do face-to-face conversation, right? So including those who don't have any computer literacy at all. So in the clinical trials of this virtual nurse with about 200 patients, one thing we always ask them afterwards is if they would have rather received their discharge instructions from their doctors or nurses in the hospital, and the vast majority of them say no. The 74% say they actually prefer the agent. So partly that's because it's an easy comparison, but they really enjoy not only the naturalness and intuitiveness of this, but they enjoy having the ability to take the time to get the questions answered that they need. So they don't feel restrictions in asking what they might consider dumb questions or asking the same thing multiple times. A second reason is I've been very interested in this notion of therapeutic alliance and how we might elicit that with a computer character, particularly for promoting long-term engagement and adherence to long-term health behavior change interventions. And a lot of the cues that clinicians use in eliciting trust and rapport and alliance are nonverbal in nature. So the facial displays of empathy, for example, immediacy behaviors, so close posture, more gaze towards the patient, more facial dynamics, and so on. So we've done a lot of studies where we've tried to manipulate these cues and show that they actually lead to higher levels of alliance, lead to more frequent logins over time when we're doing longitudinal health behavior change interventions. So a lot of these cues would be very difficult to do if you just had a text-based or static image-based interaction. And then a final area I'm interested in is explaining complex written medical instructions to patients with low health literacy. So we have an NCI grant right now, which is to help patients with cancer through the oncology clinical trial process. And if you've seen the protocols for oncology clinical trials, that I can't understand. So we're trying to find ways of having an agent walk a patient through these and explain them in a way that a patient can understand. And when we study clinicians, in addition to doing things like teach back, they do a lot of nonverbal behavior to orient the patient through the parts of the document that are being talked about, looking at gaze cues of signal understanding and emphasis and so on, and trying to simulate that in the interface. So we've built these systems for a number of different platforms, so desktop systems and hospital kiosks, IVR, and also mobile devices, which I'll talk about in a moment. And I just want to talk briefly about a couple of projects that we've used in the mental health space. So one is on antipsychotic medication adherence for patients with schizophrenia. So this is in collaboration with the University of Pittsburgh School of Nursing, Psychiatric Nursing Department there. And in this system, it was on the laptops that we provided to participants for 30 days, in which they had a daily counseling conversation, first around just system usage, so trying to get participants acclimated to the system and coming back and using it on a regular basis, then gradually introducing topics of medication adherence, and then a couple of weeks into the intervention also introducing exercise promotion as a third arm of this intervention. So we had 20 participants in a 30-day quasi-experimental study. One participant developed paranoia about the character and refused to use it, but the rest of them got through the intervention fine with very high levels of satisfaction. So by the end of the 30 days, they all had a rating of 5 on a 5-point scale for satisfaction. When we asked them about trust in the character and liking of the character, saw high levels of ratings there. And I don't have time to go into all the results, but maybe the most important is the self-reported medication adherence was very high across the population. We're also doing a project, this is with the JP in Boston, looking at substance abuse screening and brief counseling in the outpatient setting. So we built an agent that administers a NIDA-modified assist screener, and we just completed a pilot study in which they had the agent administer this to patients in the waiting room, and then they had a research assistant administer the paper-based NM assist. We showed very high levels of agreement, and of the 16 discrepancies, 13 of those involved patients disclosing things to the agent that they did not disclose to the human research assistant. And overall, very, very positive responses to this technology as well. And then finally, I just want to mention a project that this is a few years ago now, sponsored by National Library of Medicine, looking at putting one of these agents on a mobile device. So we were very curious about how people would interact with an animated character in the palm of their hand, and how this would compare to more traditional text or text and static image-based interfaces. So in this case, it was a virtual exercise counselor. We had an integrated accelerometer in the device that could detect walking, so we're trying to do walking promotion. We had individuals schedule a couple of times a day that they would go for bouts of walking. So at those times, we knew if they were doing it or not, and we could try and intervene in the moment, and then look at different media for doing that. So one of the early studies we did was just looking at doing a counseling session using text messages only, text messages with a static character, or text messages with an animated character. And in this case, it was a single 10-minute counseling session around some topic of health, and found that when we added the animation, we saw significantly higher ratings of working alliance and higher ratings of perceived caring of the character compared to just text alone or text and static images. And then in the field study with the exercise counselor, we looked at 4 conditions within subjects' design. So they had each of these for a week. So cueing was just reminding them that it was time to go for their walking bout. The non-real-time agent reflects what we normally do in these things, which we gave them the real-time reminder and then had an end-of-the-day retrospective review about how well they did on their walking, and did things like positive reinforcement if they did their walking, and problem-solving if they didn't. We then looked at moving that counseling in the moment. So at the moment they're supposed to be doing their walking. If they didn't do it, we try and engage them at that point in this counseling conversation using text messages, and then also doing that in the moment counseling using the agent, animated agent, and found significant differences across these conditions. These are percent increase over baseline and steps per day walk. So with the highest being with in the moment counseling with the animated character. So trying to look at how different media for delivering these kinds of messages might have differential impact on participants. Okay, so I'll close with that, but reiterate something that's been mentioned a couple of times this morning is we're particularly interested in how we maintain sort of very long-term engagement with these systems, and looking at how expert clinicians do this and how they keep their patients engaged in interventions using different kinds of social cues and behaviors.
Great, thank you, Tim. So our 4th and final panelist today is Dr. Niels Rosenquist, who's an instructor of psychiatry at Mass General and Harvard Medical School. He's trained as both a psychiatrist and also as a PhD in economics from Wharton School, and has been involved in multiple areas of research, including social media analysis, mobile mood monitoring, neuroeconomics, and social networks. So Neil.
Thank you, Lisa, Andrew, for inviting me here today, and thank the committee for setting everything up. This one? That is this one? So I'll speak briefly, and I want to talk about two kinds of wow. The first kind of wow came to me a couple of years ago when I was doing a postdoc in complex social networks at Harvard, and I ran across some colleagues that were doing some things that really just blew my mind, something out of the matrix. And this is a video that shows the mood of the nation with Twitter. This was like 2010. So using natural language processing, you can look at various sentiment tweets. This has become very popular now over the past couple of years. I use this with my wife to claim that we should move out west because green is nicer, red is less happy. I can say that's by experience pretty true. And I thought about it and said, my gosh, as somebody who's trained in psychiatry, you can look at these patterns, almost like a weather forecast, right? You can look at patterns of mood across the nation. It varies over time. There's some very interesting implications in other areas. As a disclaimer, I'm actually the CEO and co-founder of a company that looks at some of these patterns. It does not relate to health. It relates to stock markets, civil unrest, things like that. But it does really capture the imagination, right? You could take these electronic signals and really do something with it. So that was a big wow for me. And I thought more about this over time and said, okay, here, go back there. Yes. You know, in my training in economics, I would sit in a lot of these panels or sometimes go to these MedPAC meetings, and we would talk about how to fund various areas of healthcare. And mental health was always the little person in the side of the room with the hat on, because, you know, we really don't want to fund this because, you know, these other things are much more important, like heart disease or diabetes. And, you know, there was a sort of a two-pronged argument. You know, the first pronged argument was, well, you know, these are the other things that really cause a lot of costs, which is true, but as you know, Lisa pointed out, the mental health causes a lot of problems as well. It causes all these health problems. And then the second argument is, well, you can't ever measure it. You know, all these other things like diabetes is a hemoglobin A1C. How many of you know what a hemoglobin A1C is in the audience? Okay, it's not a very good test, actually, but it tells generally sort of rates of change of how people are adhering to their medications. Or a Holter monitor, for example. What is that? What is an EKG other than an electronic signal that is interpreted in a way that relates to health? And as I thought more about this, and I think a lot of people in this room have thought about it, and it's wonderful to be part of sort of a group like this that's thinking about this, is, well, you know, you can start to talk about how to perform essentially integral calculus on people's mood states over time. And the idea being that as a clinician, I see people once a month. I try to make inferences about time variance within that time. But point in fact, we know that there's a tremendous amount of variance that, if measured appropriately in ways that are linked with reality, are very exciting. And I have some work I'll be happy to talk about that I'm working on right now at Mass General in this area, as well as some work on a population level, looking at Google search and Twitter messaging with John Ayers and others that I, again, be happy to share with you. But for today, in these brief couple of minutes, I wanted to talk about, you know, how this first wow relates to the second wow. In this slide, I would be happy to share with any of you who are trying to make an economic argument for why this stuff is important. This was a team of Wharton MBAs that I was fortunate to have working with me last year, coming up with some fairly solid estimates as well. How much money would you save on readmits for mood disorder hospitalizations? Just mood disorder hospitalizations, and based upon, you know, let's say 10 to 15% reduction, for example, based on devices that would pick these things up early. A canary in a mine shaft, if you will, with regards to signals being picked up on a phone and device. And as an aside, I would note that when people are talking about sort of monitoring symptoms, my experience working with clinicians is if you talk about things in terms of a second order condition, dynamic rates of change of symptomatology, people get a lot bent out of shape about interpersonal, you know, this person's different than that person, how can you measure these baseline things? People are always going to be different at baseline, but rates of change are important, and biased but consistent estimators are very helpful to look at these rates of change if turned into something useful. So this is an example of the billions of dollars that can be saved in an area of the ACA. And this is what I mean by the second wow. Because when you're talking to people who are trying to fund these things or in this sequester, post-ACA passage time of great uncertainty, how you can convince people of these things is to cite some of these numbers very specifically. And another thing I would notice that when it comes to mental health as a condition, don't be afraid to do cost effectiveness either in citing. That when you're talking about what do you want to focus on, maybe the most important thing is to focus on mental health and picking up things like mood conditions. This is another example. We did an estimate just with the partners MGH. We were fortunate to have a number of the partners' leadership and MGH psychiatry leadership inform this. Look at, hey, even within just this hospital system, this is the amount of inpatient savings that you would have from reduction of readmissions. Then the other thing I would mention, for those of you as a wow, for maybe who are seeking funding from pharmaceutical companies or others, talking about placebo effects in clinical trials. So, for this interest, so we've had a fair amount of success with pharmaceutical companies who have a problem where placebo effects are huge and are likely higher than or reported higher than they actually are due to a number of reasons for patient selection in the trials, et cetera, and in terms of self-report. And again, sort of as a road ahead, when you have the ability then to have something that's not necessarily completely self-report from an individual, you can use that data to sort of confirm or see whether or not these placebo effects by self-report are overestimated. Again, I think it's another very powerful sales pitch to people within this industry, and we've had some useful success there. Again, this is just talking about the cost of drug development these days, and as many of you know, the CNS pipeline is not doing particularly well, in part because of this issue of placebos, the placebo effect sort of overpowering results in this standard FDA model. That's pretty much all I had today. I'm happy to talk a little bit more about the specifics of what I'm doing. I just would say to all of you that it's wonderful again to be here, like-minded individuals who think in this field. I've had my own personal challenges trying to span areas. I mean, some of my Twitter work was one of the NIMH leadership presented this work, and it was funny because on the paper that it was from, my name was last, and so he said from Dr. Rosenquist's lab. But in fact, in computer science, as many of you know, it's just purely in order of who contributed. So I was very embarrassed to say, well, actually, I really didn't do anything. And the flip side of it was when I go to my department and I tell them, listen, this is really exciting. It got accepted to this amazing conference. They say, well, conference, who cares about conferences? What about journals? Journals are what are important. And I sort of had to explain, well, computer science is a little different. I think actually this is very helpful. But it does reflect, I think, sometimes the bridges that need to be sort of made between these disciplines. But again, the work that everyone's doing here today is, I think, making that happen. Thank you.
Okay. Okay. All right. So we have about 15 minutes for questions. Your agenda says we're going to stop at 10:45, but we're actually going to stop a little shy of that, about 5 or 10 minutes before that, because Misha Pavel from NSF, who you've seen a few times here on Skype, is going to make some comments at the end of this panel. So we have about 15 minutes, and feel free to ask questions of any of the panelists. I surely have questions about Dave's comments about our supposed wedding, but I learned about it for the first time today, but we can save that for later. We'll bring the microphone to you if you have questions.
Hi, I'm Jaeyeon Jung, Microsoft Research. It's all fascinating work that I hear about. I don't do any research in health, but I'm looking at mobile privacy and stuff. I guess my question is, maybe to David and Sarah. So in the security and privacy, the kind of usable security and privacy, one of the issues is kind of habituation, right? So we want to intervene users, presenting some warnings and stuff, saying that, oh, you shouldn't do this and that. but after a few times, you just sort of, are habituated to these warnings and then tend to ignore. So I'm sort of curious, maybe David, in this addiction study, when these participants are facing this agent, I'm wondering whether there have been some cases where they just, at some point, starting some point, they just, ignore those and, become ineffective.
Absolutely, yeah. It happens all the time. We in our training warn people about, for instance, in the social media stuff, about how important it is to maintain your privacy and not share your names and things like that. And then each time that you go into the discussion group, those same warnings apply. This year we had the 20th anniversary of a group of breast cancer patients, women who jointly visited Walt Disney World because they had formed a strong relationship among them. They ignored the warnings, they shared who they were, they got together face to face over time at meetings from around the country and this kind of stuff, and that's the positive. But there's also, in our aging work, my golly, the old people are, like me, are incredibly worried about scams and are incredibly worried about their safety. They will not touch Google. They will not touch Facebook because they feel like everything that they say is going to be shared with the world. And so they're a group that take it more seriously than others. But it's a real problem.
Hi. Hi, Chuck Parker with Continue Health Alliance. Yeah, I heard a couple of comments today about devices that you think may be actually usable by the individual, either real or hypothetical. What type of devices do you see? Is it something that's going to be something that's quantifiable from a device capability to measure somebody with mental health issues, or is it something more along the lines of perhaps surveys and patient questionnaires? And you could talk about a hypothetical device if you think that those are if they don't exist today.
I've followed with great interest a lot of secondary devices. Like we were talking last night about some of these galvanic skin response things, or that band that I forget who comes up with, the Fitbit, et cetera. And one of the things that I've asked people around in the CS world, like, is there a convergence device for health? Is this going to be the convergence device for health? Because there's clearly a lot of things that can be done with it. I know that people follow with great interest of what the FDA thinks about that, because I know that has been a big issue in terms of spurning things. But as somebody who works with a lot of people just with regards to mental health, each additional device or thing you ask them to put on or do something is exponentially decreasing the likelihood of any of it to work. And that's just a general rule of thumb I found. So maybe there will be a way to have a single other thing to have. I don't know, but for now, I think this is probably the best hope for most stuff.
I'm Susan Buchholz from Rush University Medical Center, and in my faculty practice as a nurse practitioner with uninsured adults, for a long time, patients have been bringing in things from the web and either referring me to websites or printing them out and bringing them in. And I think I've been able to pretty quickly sort out, is that reliable or not, or to at least a fair degree of safety, and maybe gear them towards something that might be more evidence-based. But now people are bringing me smart app information. Right. Okay, I have maybe 5 minutes left to see this patient. How do we as providers sort out, is this the best that my patient, for them to use? Is it safe for them to use? Is it reliable? I'm feeling, and I do this type of research, and I'm filling in over my head. So any advice on how we quickly do that?
I'll make a... Oh, no.
Go ahead.
Well, I think you touched on a very important point. I'm struck by when I go a lot of these hacking health seminars and things, everyone wants to redefine healthcare, change it. And I sort of described it as like the invasion of Russia by outsiders. Everyone thinks it's a good idea until they try it. And so you have to sort of acknowledge the fact that there are certain things that are oftentimes overlooked. And talking exactly about one of the things I've been working on, which is, okay, how do you get this information transferred to the provider in a way that deals with these privacy concerns, that deals with the CYA concerns of clinicians, right? The last thing you want to do is have a page go off at 4 in the morning saying, hey, my bipolar patient just ordered $10 million worth of goods off of eBay, right? I mean, these are the things, you have a system in place and you need to be sort of on and off the clock. But I would just say it's an absolutely important issue. And ideally, I think systems that allow things like printouts or an easily deliverable that is actually helpful to the clinician and not just a bunch of diagrams everywhere is there. And I think with consolidation of apps, as people start to settle on one thing or another by system or otherwise, that'll make it that much more efficient.
We need to temporarily pause the Q&A. We've just learned that Dr. Pavel has some time constraints and needs to get off the line. So he's going to make a few comments now, and then we'll have some time to resume this. Thank you.
Go ahead, Misha.
Okay. Well, I'm sorry. I was assuming that I was going to speak after 9:15, and so I have an appointment I have to make very shortly. But I have a bunch of slides, but I'm going to go very quickly through those. And just to emphasize the importance of bringing rigorous science into mobile health. Because sort of supporting Wendy's idea that doing a little bit here and a little bit there is very useful and important, but it's not going to make the huge difference that we need to. I'm going to outline the notions of changing healthcare, but not talking about it because you guys already did. But here's a picture just for you to support a previous speaker of what needs to be done in order to make a difference in. I don't know. Can you see my slides?
No.
Not yet. Okay. Sorry. Nobody said anything.
So that's right. You can.
See them now?
No.
Not yet.
There. No.
No?
Hands are dated. Oh, yes. Yes.
Yes.
Yes.
We see them now, Misha.
Okay. What we skipped doesn't matter. This is the basic idea of the future healthcare that's put by IT as viewed by a number of organizations from inter-agencies groups that are working on these problems. And clearly, you need a lot of sensing on the right side and a lot of intervention on the left side. I don't have time to go through the details. Additional, of course, in making this work, you need a very strong mobile health infrastructure and other changes that I think the previous speaker mentioned. The kind of challenges that we're facing as from a computer science perspective, there are many. This is one of them, what I call source invariant. Source invariance. All these devices have to actually work together. Any one of them is going to make a very small change in the actual, or a very small difference in the actual healthcare delivery. But by making them work together, harmonizing the data, and enabling this big data to be used in point of care is going to hopefully transform medicine and health and preventive healthcare into the future. The focus that I have had with my work at the university at NSF is on behavior, because we have so many cool ideas, as Wendy brought up, of sensing this and that in physiology, but behavioral assessment is much harder to do because it's much less well defined than physiological change. Nevertheless, there are huge motivations for behavioral assessment that range from detection and diagnosis and to behavioral phenotyping, behavioral markers, epigenomics, and so on, and optimizing rehabilitation. Again, I don't have time to talk about it, but I could talk about it for hours. This is one example of why behaviors are so important in healthcare. These are data from the early 2000s, indicating that 40% of premature mortality is attributable to behavioral issues. And of course, behaviors are very difficult to deal with because when we expose with choice, we often make wrong choices. Here is a view of mobile health implications or mobile health implementations. On left side, you have the individual that's being sensed, and there are many ways of using mobile technology to sense. And many of them were discussed in this conference, and Wendy mentioned a number of the cool ones. But they have to be processed and interpreted, and you have to make inferences. And then you can, through the top layer, actually do intervention. Of course, the cloud computing is currently one of those necessary things we need to talk about. The data I'm going to talk about is basically static data from, not from mobile sensors, but from home monitoring done in Oregon. And just to indicate what kind of big data we're talking about, these are data from one person monitored for 1 year by passive infrared sensors, and each circle is a day, and the year begins here and ends over here. Every day starts at 24 hours and then goes on. These are the night hours. You see this person slept well during the first half of the year, then poorly the second, makes breakfast and so on. Now, to interpret these data, but you really need to be able to build computational models. And this is my soapbox. That's why I wanted to make sure that I talk here. You can measure speed of walking, for example, but unless you start using statistical models to figure out what the changes are, you wouldn't be able to detect them. Here is a person being monitored over 3 years, and you see the speed of walking is declining, and this is a very common indicator of cognitive decline. In fact, this person was identified with cognitive impairment, mild cognitive impairment, about 2 years into the program. This other person had a stroke, and again, this is just to show you that these are real data from real people, and in order to interpret them, though, you need to build computational predictive models. Without those, we are going to be in trouble, because we have this big data for populations, but we typically have very small data for individuals. And without actually building computational models, we will not be able to use the big data at the point of care. And I'm not going to spend any time on this, but just to suggest to you that even things like measuring gait, that is really indicative of cognitive function, requires us to model both the sensors as well as the cognitive system that generates the gait. And here is a model that I'm not going to talk about, a hybrid cognitive control model that actually tells us how cognitive control is implicated in gait. These kind of basic fundamental computational issues need to be addressed, and this is what led us to develop a smart health and well-being program early on, and more recently, as Wendy mentioned, was converted to a joint NIH program. Each proposal that is competitive has to fill a research gap that exists in science and technology in support of health and wellness, but also advance in fundamental way science or engineering. These are the institutes that are involved on top of NIH, and here are the NSF directorates. And I'm going to end with these few take-home messages. Model first, ask empirical questions later. Model me is building predictive models of an individual, because you don't want to model some average person and make a decision on the basis of those models. And finally, the multi-scale models must include behavior and context. I already mentioned for transdisciplinary teams. Thank you.
Thanks so much, Misha. We know that you need to leave, but thanks for joining us. We have just under 10 minutes or so for questions, and I think the next question was over here.
So I'm Deepak Ganesan from UMass Amherst, and I think Misha actually kind of talked about some of the things I was going to ask. But anyway, I'm interested in addiction research because we've been doing things with wearable sensors and detecting drug usage, cocaine usage, in particular smoking, and so on. And I was generally, so the question is, for at least the panel, if you look forward 5 years, where do you think the big breakthroughs will come in the area of behavioral or mobile behavioral sensing, inference, in the interventions? And there's a lot of pieces of the puzzle, right? There's that sort of the unified sensor, if you will, that people don't have to carry around these 10 sensors. There's perhaps the sensitivity and specificity of the detection itself, which is very hard, right? Behavior is not like, as one of the speakers mentioned, it's not like arrhythmia. Or is it in the interventions, and how do you figure out what people want to hear at the right time? I mean, where do you see the biggest challenges in where technology or computing and electrical engineering can play a role?
Well, I'll just make one comment. I think the science needs to catch up with the technology. And so getting to the previous question about how do you evaluate apps and how do you know which apps to use, I think the question of what happens in 5 years will in large part be driven by the research, if we can sort of do it fast, about what works and what doesn't work, and how much is enough in terms of dosage and such.
I guess one thought that crosses my mind is built around the idea of integration. I think there's going to be a lot of interesting technologies that are out there, but I think the real question, or an important question, is how do you pull these things together to make a difference in the lives of people? And I just supplement that by saying that I hope one of the things that's going to happen over the next 5 years is that we get away from the concept of patient-centeredness and move to family-centeredness, and that we get away from the idea of thinking that health is a medical issue, and that what we really do is think about how we can influence a whole mess of environmental aspects that will ultimately influence health. If you want to cut down on admissions for elderly people, you're going to cut down on falls. That's one of the things. If you're also going to cut down on not on medication adherence. As it turns out, the real issue is taking 4 different medications, too much of them, and those account for 67% of all medication at readmissions. And so I think sooner or later we're going to spending time understanding our customer, and then understanding really what the essence of these problems we've identified have been, and then integrating various kinds of solutions to tackle those things rather than doing one thing.
I would just add to these comments. I would look at a 2x2 matrix of how society thinks about privacy and incentive structures. And when I say incentive structures, I mean how much money are hospitals losing on readmissions? Because in 5 years, if there's a system in place where everyone's freaked out by privacy, and this is still a world where that is up in the air in Silicon Valley and everywhere else as to what people are going to feel about it, if sort of things go towards more and more concern about privacy, I think these sensors and other things are going to be less important, and there's going to be quant self sort of focused. So like iPhone devices and people themselves have to engage. I think if ACA turns out to be a complete, well, I realize this is recorded, challenge financially moving forward for healthcare systems with ACOs and other things at a high rate of speed, I think you're going to find more and more incentivization on the part of systems to pay patients to actually do this stuff. And the moment you start to include dollars in it, even if there's a high willingness to accept for these people, for a lot of these, high rotation people who come to the hospital all the time, it's pennies on the dollar. But those are the two unknowns that I think will determine really the kind of technology that's going to be sort of focused on.
Hi, Melissa Miner, Faculty and Staff Wellness here at Dartmouth, and I wonder if the panel has any comment on the role that employers can play in facilitating access to mHealth. There's certainly firewalls, but I think that there's a role that employers can play, and I just wonder if you have any comment on that.
Payment and reimbursement.
Could you elaborate?
Well, I think employers are one distribution channel through which what sort of payment for how to use these things is a challenge in this healthcare environment, and I think employers through their wellness plans and insurance demands are a nice potential avenue to actually pay and receive the value if they can see the value of using these tools.
I would just say there's a shop out of Boston called H-Engage. It's a company that really uses text messages for employees to actually do the stuff that employees are supposed to do, like fill out their health insurance form or something like that. And their experience in some of their published research suggests that, actually some of these network effects are very powerful. Like, hey, look at what the other people are doing, in your shop. And it's all anonymized, but you're lower or higher than average. And it actually sort of drives engagement. I think that's one way. I think mental health is a bit tricky because even though presenteeism, the idea that you show up at work, you're depressed, but you don't do anything, is a huge issue for companies. Because of stigma and other things that we're all too well aware of, it's a little bit of a higher bar to try and engage that in a company context.
David Aylward from Ashoka. One, thank you for a terrific panel presentation. Two questions. One, a couple weeks ago I was at the Las Vegas convention of the National Community Mental Health Association, which is kind of an interesting thing just to begin with, being Las Vegas and mental health. But the gap between what you folks are talking about and what's actually happening in the field and it is enormous. And I didn't see a lot of solutions to how you move knowledge into the field rapidly, particularly as you broaden from mental health to wholeness, and include physical health, number one. And number two, I spend most of my time in Africa and South Asia, where we don't have psychiatrists, or there are very few of them. Could you folks address, and the only solution would be avatars and cell phones and so on, which we're very excited about. So if you could address that piece as well.
Oh, yeah, right. I don't know. I guess, one of the things I've convinced myself of is that I don't know how to do this. We have this particular grant where our job is to get these aging technologies out to 23 of the 70 counties in Wisconsin in 3 more years. And we're working in Milwaukee and in a rural area and in a suburban area. And the issues of community organization and really getting in there and involving the community and developing relationships with leaders, both informal and formal leaders, stuff that I've never had to deal with before, it becomes so important if you want to rapidly disseminate. So we're showing a few results. There are maybe, 7 or 8 communities in Wisconsin that now want to be called elder tree communities. And these are communities that have decided that together they're going to take this technology and implement it over the next year or so. But God, it's a lot of work. And it requires skills. I don't have Gene Nelson, who's sitting in the back, is working on a great project in this area, but also has national implications on how to widely disseminate and really influence communities in terms of their health. And he knows 40 times more about this than I do. Did I suck you into it, Gene?
We're running low on time. Was that a quick comment that you wanted to make, Mary, as a follow-up? Okay. And then this will be the last comment we have time for.
Yeah, I think this just highlights the issue that people aren't the only, the end user isn't the only stakeholder we need to engage. We really need to engage payers, employers, CMS, Medicaid. Those are really important stakeholders that just need to be a part of these conversations starting now and moving forward, because service delivery organizations. You know, I'm trying to get mental health centers across New Hampshire to provide something via technology, and I can't make it happen, you know. So we got to work on that.
Well, please join me in thanking the panelists for their excellent presentations.